third and final installment for the physiology of the endocrine system and pathophysiology of the endocrine system. And to just remind you, this is a good overview of the endocrine system, but clearly there are other glands that I have not addressed in this lecture, and they will rear their ugly heads in later lectures. For example, the pancreas, when we learn about metabolism and metabolic disorders like diabetes mellitus. So, of course, there's much more to cover, but we're going to put those other glands in a discipline that's better suited for them. So we're moving on to the adrenal glands. And the adrenal glands are found on the superior surface of the kidneys, and they really are two different endocrine glands, and they have very different embryologic origin. The adrenal cortex is epithelial derived, and the adrenal medulla is really an extension of the sympathetic nervous system. In fact, the adrenal medulla is populated by a specialized set of modified postganglionic sympathetic neurons, and I hope most of my students out there know what that means. And their proper name now are the chromaffin cells. So I'd like to just address the adrenal medulla very quickly, because the adrenal medulla really is better suited in our nervous system discussions. Of course, we think of the norepinephrine being produced by the chromaffin cells, converting most of that into epinephrine, which is released into the bloodstream. And this targets most cells of the body. And just most notably, of course, we think of the pounding heart and elevated heart rate. And there's vasodilation of blood vessels to the heart, which is good because now it's working harder. We see that there's more efficient muscle contraction, better use of ATP in skeletal muscle. Oftentimes we hear of the panicked mother lifting a car off of her toddler. There's mobilization of alternative fuels during this fight or flight response, most notably from the adipose tissue releasing fatty acids. Of course, we also think of increased mental acuity and alertness. If you're running for your life, you better look around and be able to find a mode of egress. We're also going to see other hormones being released to help augment in this fight or flight response. Of course, thyroid hormone is permissive, so we're going to see more TSH released by the anterior pituitary to stimulate more thyroid hormone release. And also, as part of the stress response, we'll see the anterior pituitary releasing ACTH to target a layer of the adrenal cortex, which I'm going to highlight in just a moment, called the zona fasciculata, which will release cortisol, to be continued. Again, the mobilization of fuels, we'll see glycogenolysis, and we're going to see glucose being released by the liver into the blood so that it can be used as a fuel source for the brain. And while you're running from that predator, now is not the time to say, hey, can we take a time out? I need to go big potty. So unnecessary organ systems are shut down, quote unquote shut down. It doesn't mean that they are, completely paralyzed. It means reduced blood flow, reduced activity. Now for the rest of this segment on the adrenal gland, I'm going to focus on the adrenal cortex. The adrenal cortex has three layers going from superficial to deep. It is the zona glomerulosa, zona fasciculata, and zona reticularis. And if you are reading Guyton and Hall, you are reading that these layers produce a combination of hormones that can act as mineralocorticoids. In some cases, they have some glucocorticoid-like activity, and vice versa. For learning purposes and testing purposes, I'm going to draw a hard line in the sand. We're going to agree that the zona glomerulosa is primarily focused on making mineralocorticoids, and the number one is aldosterone. We will talk about aldosterone just minimally here in this lecture, because again, our focus is on the HPA pathway. And of the layers of the adrenal cortex, really the only layer that directly responds to that mode of communication is the zona fasciculata. So I'm just going to superficially address aldosterone. It's going to target certain cells in the kidney, specifically of the nephron, and it will increase sodium and water reabsorption, this comes at a cost of secretion of potassium. Aldosterone will be our focus later on in our semester when we learn about salt and water balance and disruptions to this balance and acid-base issues as well. So to be continued. The zona fasciculata, it's primarily responsible for making glucocorticoids, and that general term means that these hormones are going to augment fat and protein catabolism and gluconeogenesis, and I will spend considerable amounts of lecture today now on this topic. So we're going to focus on cortisol. There are other kinds of glucocorticoids that are made, corticosterone for example. We're just going to use cortisol as our prototypic hormone from this layer. The zona reticularis is going to be a site of androgen synthesis. And the androgen of question is DHEA, and I will show you when this can be an issue. But the androgens from here are small, yet they can be important and rare manifestations when communication to this adrenal cortex is broken. Now for a man, the androgens from this layer do really nothing significant for him for his secondary sex characteristics. But for a female, the androgens from this layer contribute to the development of axillary and pubic hair. This is a pathway showing how through all the layers of the adrenal cortex there is a common precursor shown up here in the top left screen, cholesterol. Now, minimal amounts of ACTH are required to drive cholesterol into the cells of the zona glomerulosa. That's what I'm focusing on right here in this slide. And then the cholesterol is progressively changed. Everywhere where you see an arrow, there's an enzyme responsible for the conversion of cholesterol to the next hormone, to progesterone, to 11-deoxycorticosterone, all the way down to aldosterone. And students think that aldosterone follows the rules of the HPA axis, and it doesn't. It's not hormonal controlled. It's humoral. It's potassium levels in the blood, or something called angiotensin II, which I have labeled up here and circled in the top red circle. So it's humoral. And therefore, it's not going to be our primary focus of discussion right now because we're going to focus on the layer of the adrenal cortex that does follow a hormonal HPA pathway. And that's the hypothalamo-hypophyseal adrenal axis. Say that 5 times in a row. Now, in here in the center picture, you're seeing the hypothalamus releasing corticotropin, releasing hormone. That will stimulate the corticotropes that are found in the anterior pituitary, a certain camp of cells. In response, they will release ACTH. This is going to target a specific layer of the adrenal cortex, most notably the zona fasciculata, in which case those cells are going to increase glucocorticoid and production and release, most notably cortisol. Of course, there will be negative feedback inhibition from cortisol back up to the anterior pituitary and the long loop all the way up to the hypothalamus. On the right, you're seeing that cortisol is used by your body for long-term stress management. We see that there are alternative fuels that are mobilized like lipids and amino acids. If cortisol could talk to you, it would say, look, you're under a lot of stress chronically. Save glucose for the brain. It's got to figure out a way from this chronic stress. You've got to deal with this. So the rest of the cells of the body that are insulin dependent, skeletal muscle and adipose tissue, they're going to mobilize alternative fuels and use alternative fuels. Cortisol is considered to be diabetogenic because of this response of more glucose being released into the bloodstream. That does not mean that the person is diabetic, however. Let's redo this topic again. What are the metabolic effects of cortisol? Well, if you follow these solid arrows and dashed arrows, the blue solid arrows show a stimulating pathway, and the dashed black arrows show an inhibitory response. Let's start here in the liver. We see that there will be glucose precursors, and these glucose precursors, like free fatty acids and glycerol, that were released by adipose tissue can go to the liver and participate in gluconeogenesis. What does that mean? It means glucose, neo means new, genesis means synthesis of. And these new glucose molecules that you didn't eat can be released into the bloodstream to be used by the brain during this stressful moment as a fuel source. Now, glycogenolysis will also occur in this moment of stress, and that means any stored glycogen can be hydrolyzed to release free glucose into the bloodstream. Notice that skeletal muscle will catabolize protein and release the amino acids into the bloodstream, and that too can be used in gluconeogenesis. Now, during high moments of stress, chronic stress, we would expect to see muscle wasting in our patient because of this catabolic effect on the skeletal muscle proteins being broken down and used for parts. Again, cortisol causes a diabetogenic effect. All of this is to stimulate, or increase, I should say, glucose in the bloodstream so that the nervous system has a fuel source. There is significant inhibition of non-essential functions. What's considered non-essential? Reproduction. Someone who's under chronic stress may have fertility issues. If you're talking about a young child, growth may be stunted. And I know what you're thinking right now. All those years of childhood stress induced by mom and dad, that's the reason why you're small, right? Come on, you can't blame them for all of your problems. And in a child, or in an adult even, if there's chronic stress, we can see bone resorption and leading to osteoporosis. Cortisol also has an effect in the immune response. It reduces significantly your immune-specific or acquired immune cells, most notably T cells and B cells. So someone who's under chronic stress is more likely to get sick with an opportunistic pathogen. Now, we can use this to our advantage in the case of someone who has an autoimmune system or hypersensitivity, in particular rheumatoid arthritis. They have chronic inflammation, and it's from their own immune system being, well, too good for its own good. So we can give huge pharmacologic doses of cortisol to this patient to abate this huge immune response. And this person, of course, would have hypercortisolism and a specific kind called Cushing's syndrome as a result. And we say it's iatrogenic or physician-induced. Now let's talk about some problems with the adrenal gland. Let's start with deficiencies. And of course, our focus is on that middle layer, the cortisol layer. Let's say there's primary adrenal insufficiency. That means the adrenal gland itself is not behaving as it should. It's dysfunctional. This is called in the old school literature Addison's disease. Now this can happen from primary hypoadrenalism. The entire adrenal gland is destroyed or atrophied. Maybe there's an autoimmune attack on the entire adrenal gland. What would you predict to see in your patient? Well, I wrote down the signs and symptoms down at the bottom of your screen in green for this case. We'd go through all the layers and expect what would occur in your patient if that particular layer wasn't releasing its hormone. Okay, let's start with aldosterone. It's missing. What does aldosterone do? Help retain water and salt. So if aldosterone is missing, you're going to lose water and salt. What will happen to your blood volume? It'll go down. What will happen to your blood pressure? It'll go down. What about the next layer? Cortisol. Cortisol helps increase blood glucose levels. Without it, you're going to have decreased blood glucose levels, hypoglycemia. Going in between meals can actually become life-threatening. Cortisol helps maintain blood glucose levels between meals. We're going to see that the person is not able to have sufficient nutrient intake because of this. Anorexia may occur. Going back to the aldosterone story, if we can't retain sodium in water, then that means we can't secrete potassium either. It'll store up in the body inappropriately. That's hyperkalemia. That is also life-threatening. Because of the lack of blood glucose, insulin-dependent cells will be starving. They will have to use alternative fuels. We would expect the patient, due to utilization of these alternative fuels, to experience metabolic acidosis. You will learn about these pathways later in the semester. For the female, lack of DHEA from that internal layer, the male androgen, we would expect to see a decrease in pubic and axillary hair. Now, why would there be hyperpigmentation? Draw the pathway. Start with the adrenal cortex. It's dysfunctional. Which hormone of the adrenal cortex follows a hormonal regulation? Cortisol. If cortisol is going down, do your feedback. What what would happen to the hypothalamus receptors? They wouldn't be populated. What would the hypothalamic cells do? They're going to release more CRH. This is going to target the corticotropes. What should they do in response? Release more ACTH. And I'll remind you, a portion of ACTH has melanocyte-stimulating hormone, just a little bit of it going along with ACTH. And that means if you have increased ACTH, this tail end of it that has MSH properties to it can target melanocytes. And you can see hyperpigmentation in your patient, as shown in the top pictures. This woman is of Caucasian descent. And notice how dark her skin is. That's from the extreme excessive ACTH. All right. Tuberculosis, for whatever reason, this disease can attack the adrenal gland. And that's why I use pictures of this woman. She was treated for pulmonary tuberculosis. The tuberculosis attacked her adrenal gland, gave her primary hypoadrenalism, and her ACTH levels went up. Now, what if the adrenal gland isn't the direct problem? What if the problem is higher up, say in the anterior pituitary? Well, the person now won't have enough ACTH being released, and the middle layer of the adrenal gland isn't getting its stimulus. But it's not that it's dysfunctional, it's just not getting its appropriate signal from the anterior pituitary. Now, this is called secondary adrenal insufficiency. It can be from a deficiency of the corticotropes releasing ACTH. But this secondary adrenal insufficiency can also be caused if someone is on high doses of cortisol, say for rheumatoid arthritis, and they suddenly decide to stop taking that cortisol. Well, let's do the feedback. If they are on exogenous cortisol, of course the cortisol levels in their blood would be high from that prescription. But endogenously, these high cortisol levels would feed back to the hypothalamus, shut down or decrease release of CRH. This in turn would shut down the release of ACTH. And this in turn would shut down the middle layer of that adrenal cortex in the patient. Their endogenous cortisol levels would go down. If they suddenly stop taking this cortisol and it's metabolized and suddenly their blood cortisol levels drop, it's going to take some time for their own endogenous HPA pathway to rev up into gear again. And this can be life-threatening. They are not able to maintain their blood glucose levels right now during this transitional time, and this is life-threatening. And it turns out the other layers of the adrenal cortex may be okay. You wouldn't necessarily predict a raging hyper-K or hypotension because you only need trace amounts of ACTH to send cholesterol into those zona glomerulosa cells to utilize cholesterol to form aldosterone. So you wouldn't necessarily see a huge problem with hyper K or hypotension, and you might not necessarily see the hyperpigmentation either. Well, you certainly wouldn't because there's a deficiency of ACTH, silly me. Now let's do the reverse. Here is a person with excessive adrenal hormones. Let's first talk about Cushing's disease. Now this would technically be secondary hyperadrenalism, where it's a problem with an anterior pituitary tumor releasing excessive ACTH. Now draw the pathway. With excessive ACTH, this would excessively stimulate the middle layer of the adrenal cortex, and we would get a lot of cortisol. What would we predict? High blood glucose levels, diabetogenic, muscle wasting. Look at this poor man. He certainly has limb wasting. What else would we predict? We would predict a inhibition of his immune system. That's a problem for us. We would also see him redistributing fat, most notably in between the scapulae. If he were to turn to the side, he would have a buffalo hump. If we saw his face would look perfectly round. It's called moon face. And again, this is from redistribution of fat. You also notice that he has very thin skin. Remember that there's protein catabolism. In addition to muscle wasting, the collagen fibers that are found in the dermis are not synthesized appropriately. So you see those stretch marky looking striae in his skin, and he has very translucent skin, thin skin. Again, that protein is also sacrificed. Now, Cushing's syndrome means that there's hypercortisolism, but it's from some other problem, not the anterior pituitary. Of course, it could be iatrogenic or physician-induced exogenous levels of cortisol. It could also be because of primary hyperadrenalism. Maybe the adrenal cortex has an over-secreting tumor, in which case we would find excessive aldosterone, too much salt and water retention, hypertension, hypokalemia. We would also expect adrenogenital syndrome. For a man, it might mean nothing significant. It's not going to affect his secondary sex characteristics. But for a female who has excessive DHEA, she might have masculinization. She might have hirsutism, you know, the bearded lady in the circus act. She might have an enlarged clitoris. So that's what we mean by adrenogenital syndrome. Now, for my pathophysiology students, I want you to look up the dexamethasone suppression test, and I want you to be ready to distinguish between low versus high dose dexamethasone test. I give you the website through our National Library of Medicine, nationalinstituteofhealth.gov. You know that's our first go-to place to look anything up. For my physiology students, if you're intrigued by how we use the simple test to distinguish between Cushing's disease versus Cushing's syndrome, please see this website. Let's talk about congenital adrenal hyperplasia. The picture shown here in the right is actually a baby girl, and yet you can see her labia majora are fused, and it looks like she has a scrotum. Her clitoris is also enlarged, and it makes it look like she has a tiny little penis. So this is ambiguous genitalia for newborn girls. Well, what is this problem? CAH. Well, students want me to, pin to the wall and say, Kara, will this lead to excessive or deficient hormones? Well, it depends on the layer of the adrenal cortex you're talking about. Excuse me, and it also depends on the genetic mutation in the gene that codes for any or all of some of these enzymes I'm going to show you. We do know, however, regardless of the genetic mutation, that it's an autosomal recessive. So you need 2 bad copies of these genes. And again, the mutation leads to a deficiency of an enzyme that is required for the progression of cholesterol to be converted, to the next hormone, to the next hormone, to the next hormone. And it's in particularly a problem when it's an enzyme used not only just for aldosterone, but also cortisol. I'm going to show you a picture of these pathways. If we focus just on cortisol and its production is inhibited, then lack of cortisol feeds back to the hypothalamus. What would the hypothalamus do? Lack of receptors bound. That will stimulate it to release CRH, and this will lead to increased ACTH. More ACTH means the adrenal glands are going to be overly stimulated, but they can't make cortisol, so they're going to have hyperplasia. It's like the goiter of the thyroid gland, right? So that's why we call it hyperplasia. There's increased cell synthesis, mitosis, but there's still dysfunction. They don't have the enzyme to code for cortisol or to help convert cholesterol to cortisol. So we're going to see it really is reduced to the following concept. Look, if there was some sort of horrendous accident on the freeway, let's say you need the freeway to get home. Do you really need the freeway to get home, or is that just the fastest way to get home? Do you have alternative pathways you can use to get home? Well, in the next slide, I'm going to show you the pathways in the adrenal cortex to convert cortisol to either aldosterone or cholesterol to cortisol or cholesterol to DHEA. If the pathway is blocked, then an alternative pathway is going to be taken. And it turns out, depending on the genetic mutation, depending on which enzyme is blocking the roadblock, can lead to this ambiguous genitalia in females. So the baby girls have virilization. That's what it means. They have the enlarged clitoris, the fused labia. But for a baby boy born with this, you wouldn't necessarily see, based on the genitalia, the problem internally. The dad, I always joke, might high-five the doctor saying, yeah, my boy looks like he's almost a man now that he's born. And I'm here to tell you that in a baby girl, it's easy treatment, it's cosmetic surgery, and then once we give her the cortisol and her HPA pathway goes back to how it should be, she'll be a normal, healthy girl, develop normally with secondary sex characteristics, and should have no problem with fertility, barring any unforeseen problem in her ovaries. So let's explore how genetic mutations in some of these enzymes through our pathways can lead to this ambiguous genitalia. Okay, so up here in the screen in different colors you're seeing mineralocorticoid pathway, glucocorticoid pathway, androgen. You know what? These really represent the 3 layers of the adrenal cortex: the zona glomerulosa, the zona fasciculata, the zona reticularis. Now, all 3 pathways, of course, make their unique signature hormone. We said the zona glomerulosa is going to be responsible for making aldosterone. Zona fasciculata, cortisol. And zona reticularis, these androgens, DHEA, dihydroepiandrosterone, which is converted to another androgen. Now look, all 3 of these pathways require cholesterol as a precursor. Cholesterol goes into the zona glomerulosa. Those cells convert it to pregnenolone, which can then be shunted to the next adjacent layer, and then that hormone can be converted to cortisol, or the hydroxypregnenolone can be converted to the DHEPA in the next layer, right? So it's shunting the cholesterol across, but then also converting it down to the ultimate hormone for that layer. Now notice, in 2 of these layers, we share common enzymes to convert one hormone to the next level. And if there's a genetic mutation in the gene that codes for 21 beta hydroxylase, or if there's a genetic mutation in the gene that codes for 11-beta hydroxylase, we're going to block these pathways. And we'll block the synthesis of aldosterone. But the reason why we see the pathology in this baby girl is because we're also going to block the synthesis of cortisol. 11-beta hydroxylase is also required to convert 11-deoxycortisol to cortisol. So if we block the cortisol, that's where the HPA pathway tries to correct this. And it's all for naught. CRH levels go up, ACTH levels go up. She gets the adrenal hyperplasia. She gets the hyperpigmentation. Look how tan she looks. And she's going to get the ambiguous genitalia. Why? The only pathway that's not blocked is the DHEA. The male androgen accumulates in her blood and causes these male secondary sex characteristics to develop in this baby girl. So I find that very, very fascinating. And this baby girl, like I said, has the virilization. If these pathways are disrupted later in life, we talked about the adrenal hyperplasia. In the older woman, she might get the hirsutism and the masculinization, the chiseled jaw. She might get the facial hair, like I said, the hirsutism. It's just a fascinating disrupted pathway. All right, now we're shifting gears to a different hormone system, the HPL. And this stands for the hypothalamic hypophyseal liver axis. And in this picture, you're seeing the hypothalamus has a choice to either stimulate the anterior pituitary to release growth hormone, or it releases somatostatin, also known as growth hormone inhibitory hormone, to shut down the anterior pituitary somatotropes from releasing growth hormone. So we have a positive signal and an inhibitory signal for this hormone pathway. Now it used to be, for a long time, thought that growth hormone was just, that was it. It was just HP. And now we know that having enough growth hormone is not enough to get proper growth. We do actually need it to target liver in addition to bone and skeletal muscle, because the liver is going to release insulin-like growth factors that help augment the activity of growth hormone in cartilage, in bone, in skeletal muscle. So growth hormone is not enough on its own. You do release growth hormone mostly in your sleep, and it is true you do your growth while you're sleeping. It's not uncommon for teenagers to have the same rate of growth as toddlers. It's true in a span of a week they could be outgrowing their tennis shoes and their jeans. What does growth hormone do? Like I said, it targets skeletal muscle. We see skeletal muscle having increased amino acid uptake and increased protein synthesis. So we get well-defined musculature in our growing teenagers. As we age, we don't have as much growth hormone, and that's why we start to see the muscle wasting and weakness in our elderly. Adipocytes are also stimulated by growth hormone. There's more fat utilization. Growing requires a lot of energy. So we're going to see the body using a lot of fat for energy production. And there could be more keto acids that are produced during this time. Have you ever noticed a teenager before their growth spurt? They eat a lot and they pack on the weight. And they do look a little flabby from that excessive fat deposition. Don't bark at them about their weight. They pack it on before they stretch, is what I say. Growth hormone targets the liver, which I showed you in the previous picture. It will lead to increased gluconeogenesis, using alternative amino acids and fatty acids to make glucose. But there is a decline in the body usage of glucose as energy. Again, the focus will be on the fats, because this is a stressful time for the body to grow. The glucose will be saved for the brain during this time of transition. It's diabetogenic. That's why blood glucose levels go up, but it does not mean that the person is diabetic. If a person has an anterior pituitary tumor during puberty, before the epiphyseal plates closed, it can lead to gigantism, when we think of Andre the Giant as an example. But if someone gets an anterior pituitary tumor after their epiphyseal plates close, we can see acromegaly in their patient. You see in this patient the pronounced brow, the huge glabella, and the large mandible from appositional bone growth, thickening. What you don't see in this picture is likely what drove her to see her physician and get help. The bones in the hands and the feet grow excessively. They thicken. That's what we mean by acromegaly. And the patients come in complaining about how their shoes don't fit. They buy new shoes, and then those don't fit the next week. So that's the number one reason why they come in. Now, what evidence did we get to suggest that having sufficient growth hormone is not enough to dictate proper growth? Well, we found some short-statured individuals. You're seeing two different populations here in these pictures. You're seeing the African pygmies. These are all adults down here in the bottom picture, and they're standing next to an average 6-foot man. And you're seeing even adult males. Look, they barely come chest height. Up here in the top right picture, you're seeing the Laran dwarfs, and there's a large population of them found in Ecuador. These two people, or sets of people, have short stature for different reasons. In the African pygmy, it's interesting. They have normal levels of growth hormone. Additionally, they have normal caloric intake. What they lack is the insulin-like growth factor released from the liver. They don't have enough ILGF-1, which is sometimes called somatomedin C. Without that, we don't get appropriate height. With the Laran dwarfs, their problem is they lack a functional growth hormone receptor. Now, ironically, this growth hormone receptor is also the same kind of protein that's used in the plasma to shuttle growth hormone. So it's not getting, growth hormone isn't getting distributed to the body appropriately and not binding to the receptors appropriately. I asked you a question in the beginning of these lecture series, what would happen if someone didn't have a functional receptor? And we all agreed it would be as if the signal weren't released at all. So I find this very, very intriguing. Of course, growth hormone is mitogenic, and it, along with its partner ILGF, will target the cartilage cells in the epiphyseal plates and leads to bone lengthening. That's what we think of with the increased height. This slide summarizes some of the redundant and antagonistic pathways of these 5 major hormones and how they can change glucose levels in the blood. I've highlighted all of these. I just wanted to put it in table form for those of you moving on to your professional schools. This might be a good table to have at the ready anytime you are dealing with a patient care plan. Again, some of these are antagonistic to each other and some of them are synergistic. And down here I have what can happen to blood glucose levels, and I've also added for 2 of them the idea that some keto acids can build up in the bloodstream as well. Growth is weird. It not only is hormonally based, and it's not just about growth hormone, it's also insulin-like growth factor, which you just learned, but it also can be an insulin deficiency that limits growth, or a thyroid hormone deficiency. There's also epigenetic issues, environmental issues. Is the person has malnutrition? Is there a lot of stress in their life? Could this lead to psychosocial delay issues? You betcha. So there's a timing and a tempo when growth is on, the onset of growth, but then also how quickly a person grows. Timing and tempo, affected not just by hormones, but also environmental factors. If you're my physiology student, you heard me talk about a little boy that I knew who was picked on and neglected by his family. His siblings picked on him, not just his older brothers, but his younger brother too. And his mother and father weren't totally dedicated to their children. They were kind of tired. They had 4 boys. And this kid just, he He's short to this day, and he's just not right. Children are pretty adaptable creatures, but when they don't have support from their family, little day-to-day stressors can seem overwhelming to them. And he just could not handle the stress very well. And he include to this the story that his dad really pushed him to play on a competitive team sport that he wasn't well suited for. A teacher, even a second-grade teacher, that picked on him excessively. My heart just bled for this little guy. And I still watch him as he grows, and he seems to be adapting better as he goes through his teenage years. He's now going to be a junior in high school soon. I just hope the best for him, but he certainly had a rough start because he just didn't have family support. In our last few slides, I'm going to focus on calcium metabolism. Calcium is found in our blood in many different forms, ionized, bound to proteins. It's the calcium that's in the anion, or complex to anions, that is free and available for metabolic issues. This patient has hypocalcemia, and you can see the tetany and rigidity in her fingers. And to my physiology students, I want you to read why. To my pathophysiology students, I want you to also figure out why. The irony should not be lost on you. Calcium is required for muscle contraction. And most students predict that the tetany would be from hypercalcemia. It's reversed. I want you to figure out why. The story has something to do with sodium voltage gated channels. Where do you find those? And what role does extracellular calcium sources have on these sodium voltage gated channels? Try and piece this together. I should be a responsible teacher and give some onus to you for your own learning. I'll help you, but you start. Parathyroid hormone is the hormone that is most responsible for monitoring and regulating the calcium level. So it's the parathyroid gland that monitors and releases the parathyroid hormone that regulates calcium levels. There are 3 primary targets for parathyroid hormone and its partner in crime, vitamin D. It's not just PTH that acts on its own. Calcium levels are regulated through a humoral pathway, not hormonal. So there's no HPP pathway to discuss here. Parathyroid glands are found embedded in thyroid tissue, and the adding clinical annoying feature is that not everyone has the same number of parathyroid glands, nor are they found in exactly the same position on the posterior side of the thyroid gland. So the 3 main targets will be bone, kidney, and intestine. And again, parathyroid hormone needs its partner in crime, vitamin D. You can get vitamin D from your diet, but you also can make it from cholesterol precursors in your skin, and the sun that you are exposed to can convert that cholesterol to vitamin D. But that's not active vitamin D. You must go to the liver and have a hydroxy group attached to it, turn it to 25-hydroxycholecalciferol. That's not active either. Then under the direction of parathyroid hormone, the kidney will convert the 25-hydroxycholecalciferol to calcitriol, also known as 1,25-dihydroxycholecalciferol. Then together, parathyroid hormone and this active vitamin D can target bone, and osteoclasts will gain more activity. I will show you how. They will release more hydrochloric acid on the bone matrix to resorb more calcium hydroxyapatite and liberate calcium into the bloodstream. The kidney, along with vitamin D and parathyroid hormone, will respond by increasing calcium reabsorption through certain parts of the nephron. And the intestine, with vitamin D and PTH, will increase the absorption of new calcium from your diet. Now, how exactly does parathyroid hormone and vitamin D lead to more bone resorption. That means you're chewing up the bone matrix to liberate calcium into the bloodstream. Well, it's through a series of signals. Now, don't let these words scare you. First, let me introduce you to these cells shown in your picture. In gray, you're seeing osteoblasts. These are immature osteocytes. Both osteoblasts and osteocytes are responsible for bone accretion, which is bone deposition. Pre-osteoclasts are immature osteoclasts. Osteoclasts are large cells that are multinucleate and have a ruffled border shown here. Why are they multinucleate? Well, because many pre-osteoclasts merge together to form a large mature osteoclast. Now, next layer. What is OPG? OPGL, the L stands for ligand. A ligand is a chemical signal that has to bind to a receptor. You can think of the keys going into your receptor called a lock. You can think of your keys as a ligand, right? They fit in the lock. So OPG simply stands for osteoprotegerin. Osteoprotegerin is the receptor, the lock. An osteoprotegerin ligand, OPGL, are the keys to unlock the lock. Now, where is OPG? Where is the lock? Those are on the pre-osteoclasts. Where does the key, OPGL, come from? OPGL comes from osteoblasts. So look at the picture. If parathyroid hormone and vitamin D levels are elevated, these stimulate osteoblasts. They in turn release the keys, osteoprotegerin ligand. The keys are going to go to the lock, OPGs, the receptors on the pre-osteoclasts. This will stimulate, unlock the pre-osteoclasts. They'll fuse to form mature osteoclasts, which will release hydrochloric acid on the bone and resorb the bone matrix, freeing calcium into the bloodstream. The fun in this story comes from when calcium levels increase in the blood, and now you don't want any more bone matrix to be resorbed. You need to stop this pathway, don't you? It's still negative feedback. You don't want the osteoclasts to have too much activity. They'll keep resorbing the bone and you'll have osteoporosis. So when there is no more PTH and vitamin D signaling, when those have been shut down, the osteoblasts, if they could talk, they would say, oh no, we've just released our keys. They're unlocking the locks. They have no way, these cells have no way of endocytosing back in the keys. It's a lot like when a person sends an email and they didn't mean to, and then they send another email saying, I'd like to recant the previous email. How do you do that? You can't pluck it out of cyberspace. It's already out there. Yeah, you could say you wish you could take it back, but you can't. So at best, you can run interference. You can maybe try and get to the computer or cell phone, to all the people you sent it to, open their email account or text messaging and try and delete it before they see it, right? You try and run interference, but you can't grab it back. So that's what the osteoblasts try to do. They try and run interference. They can't pull their message back. They can't pull back the keys, so they try and interfere. They try and entice it away from the pre-osteoclasts. And what the osteoblasts do is that they will send out a decoy. They can send out their own OPG. That's right. They can send out their own lock. But it's not anchored to a cell. It's just hanging out there. So any OPGL they've already released will now be torn between either the lock found on the pre-osteoclast or the lock that's just hanging out in cyberspace, if you will, quote unquote. So there will be less OPGL getting to the locks, OPG, on the pre-osteoclasts, and that means fewer of them will be merging to form osteoclasts. fewer osteoclasts means less bone resorption. Try and map that one out if you can, pathophys students and physiology students, because for my phys students, it most certainly will be on your test. All right, that concludes our